Now this is a pented which I was discussing. Now we come to the uh, how do we diagnose nephritic syndrome? You see, certain things are very helpful in narrowing down the differential diagnosis of acute glomerulonephritis or nephritic syndrome. Like if the patient is young, there are possibilities that he or she may be having IgA nephropathy, post-streptococcal, henoch-Schönlein purpura, HUS, or arrhythmia. If he is adult, then there are chances of that he or she may be suffering from good pasture, SCD, RPGN, infective endocarditis, or MPGN. But remember, there is overlap also. In gender, SLE is more common in females. If it is associated with a respiratory infection, then one should think in terms of post-streptococcal IgA nephropathy or ANCA vasculitis. If patient has got hepatitis C, then a differential diagnosis is MPGN and cryoglobulinemia. If hemoptysis, there is Goodpasture syndrome. If oliguria, anuria, and abdominal failure suddenly of short duration, it is RPGN. If fever, malaise, abdominal pain, PFGN, and henoch-Schönlein purpura. If there is patient presents with frank hematuria, possibility is IgA nephropathy. If patient has got purpura, then there are chances that he or she may be suffering from henoch-Schönlein, thrombotic thrombocytopenic purpura, or there may be a malar rash of SLE. If diarrhea, especially with bloody diarrhea, hemolytic uremic syndrome. And if there is a family history, there are chances of Alport syndrome. These are only a guide to narrowing down the differential diagnosis. On examination in patient with nephritic syndrome, we may find edema, but edema is not significant as in nephrotic syndrome. There may be signs of fluid overload because of hypertension and heart failure, raised JBP, gallop rhythm, and chest crackles. High blood pressure, abnormal heart sounds are seen in infective endocarditis. Tender abdominal and flank pain can also be a feature. Purpuric rash can be seen in henoch-Schönlein purpura. Fever, throat examination as in IgA nephropathy and post-streptococcal, and patient may present with no deformity indicating towards Wagner's. In lab investigation and linear analysis, we will find hematuria, proteinuria, dysmorphic RBC cast, and cytopenia. Then we have to do CBC to exclude different types of hemolytic anemia, raise PU and creatinine to establish impairment of kidney functions, electrolytes, LFTs, ANA, anti-DNA, C3 and C4 to exclude SAD, and anti-GBM antibodies for Goodpasture syndrome. ANCA for Wagner's granulomatous, ASOT for post-streptococcal hepatitis B and C for membranoproliferative blood culture for infective endocarditis. X-ray chest can be helpful in identifying infiltrates, and ultrasound KUB for the size of kidney, and proceeding with the kidney biopsy to identify and establish the diagnosis. Kidney biopsy is the ultimate tool for the diagnosis of nephritic syndrome. The management main goal of the treatment is, regardless of the cause, is to control, reduce active inflammation of the kidney. We have to salvage kidney, may need to be admitted for monitoring and treatment, best rest for early recovery, optimal therapy to avoid aggravating factors, fluid restriction to avoid and manage edema, diet restriction for sodium and potassium, diuretics for fluid overload, antihypertensive to maintain blood pressure, and avoid nephrotoxic drugs, infections, and hypovolemia. Then once the acute phase of nephritic syndrome is controlled, efforts should be made to determine the pathology. Example, renal biopsy, and then treat specific conditions with steroids, immunosuppression, and plasmapheresis. If pathology is not identified and treated, there is increased risk of progression to chronic kidney disease. And if kidney failure, RPGN example, patient will be needing renal replacement therapy. The prognosis of nephritic syndrome is a serious disorder as compared to nephrotic syndrome. And the prognosis depends on the underlying cause. Generally, the prognosis in children is better than adults. In RPG, and the prognosis is regarded. Most of these patients may end up in end-stage kidney disease. Incidence of progression to chronic kidney disease leading to end-stage kidney disease is high, and death usually occurs as a result of complications like hypertension, low overload, hyperfailure, heart failure, hyperkalemia can lead to cardiac arrest, infection, and renal failure. Now we come to we have already discussed two types of glomerular diseases like nephrotic syndrome and nephritic syndrome. And today onwards, we will be discussing the tubular disorders. And in this, first is the tubulointerstitial nephritis. It was first described in 1898 by Conselman. There is inflammation of the interstitium and renal tubule. And remember, interstitium is 80% of the renal volume. Interstitium is basically the supporting structure of the tubule. The supporting structure of the glomeruli are the mesenterium. Glomerular capillaries are supported by the mesenterium, whereas the tubules are supported by the interstitium. It consists of collection of cells called fibroblasts and macrophages. It has got extracellular matrix and then the fluid surrounding the renal tubule. These all collectively are called mesenterium. Interstitium. The function of interstitium is support the tubular structure, as I have already told, fluid electrolyte balance, and it also performs endocrine function like erythropoietin and prostaglandins are produced in interstitium. Basically, tubulointerstitial nephritis are of two types: acute tubulointerstitial nephritis, which is a 15% cause of acute kidney injury, intrinsic kidney failure, and chronic tubulointerstitial nephritis, which has a chronic course leading to CKD, chronic kidney disease, and ultimately end-stage kidney disease. Chronic pyelonephritis is also a type of chronic interstitial nephritis. The term chronic pyelonephritis is no more used. The usual term is chronic interstitial nephritis. Acute interstitial nephritis, various etiologies like infections in pyelonephritis, and medication is the most common cause of acute interstitial nephritis. Drug-induced interstitial nephritis is the most common cause, almost 70%. And in drugs, antibiotics, antivirals, analgesics, gastrointestinal drugs, in fact, any type of drug can cause acute interstitial nephritis. The classic example is NSAID-induced interstitial nephritis. Penicillin can cause interstitial nephritis. Antiviral can cause interstitial nephritis. In fact, even diuretics like furosemide or hydrochlorothiazide can cause interstitial nephritis. Anti-cancer drugs, allopurinol, and herbal medication. Very huge etiology of interstitial nephritis, which is mostly drug-related. The clinical features are usually non-specific, should always be suspected. It's a difficult diagnosis. The drug induces the most common cause. NSAID is the most common drug, which can be a cause of nephritic syndrome. But remember, NSAID can also cause nephrotic syndrome. Fever, rash, and arthralgia is usually present in patients with acute interstitial nephritis. Nausea, vomiting, lack of appetite, fatigue, weight loss, oliguria, dysuria are all features of chronic kidney disease. Low back pain may be present with enlarged kidney and mild to moderate hypertension. Diagnosis is by history and examination, especially drug history. Eosinophilia is present in 50% of the cases. IgE is present. It can also be found because it's a form of hypersensitivity reaction. Hyperkalemia because of kidney impairment. Metabolic acidosis because of kidney failure. Raised urea creatinine because of kidney failure. Previously, eosinophiliuria, that is eosinophil in the urine, were diagnosed with the help of Wright and Ansel stain, but they are no more used. Hematuria is also can help you in diagnosis of acute interstitial nephritis, sterile pyuria, WBC cast, but no RBC cast. RBC cast are seen in acute nephritic syndrome. Non-nephrotic proteinuria, the NSAID, as I have already told, can present with nephrotic syndrome as well as acute interstitial nephritis. Kidney biopsy is diagnostic, in which you find interstitial fibrosis and inflammation of the tubular cells. Treatment is treat the cause, withdraw the drug which is causing, and treat the infection, educate hydration and nutrition. Low dose steroids are also given in patients with acute nephritis, that is 60 milligram per day at tapering. 1/3 of the patient may need dialysis because of acute kidney injury. Most cases recover in 4 to 8 weeks, or the remaining can land up in chronic interstitial nephritis. Chronic tubular interstitial nephritis is an incidental finding, especially in patients who come to you with kidney failure, with bilaterally small shrunken kidney, hypertension, impaired kidney function, and chronic cause. Any cause of acute interstitial nephritis, if not properly managed, can lead to chronic interstitial nephritis, and chronic interstitial nephritis is an important cause of end-stage kidney disease. The causes of chronic tubular interstitial nephritis is chronic pyelonephritis, which may be unilateral, bilateral with scarred shrunken kidney, obstructive uropathy because of any cause like calculous disease, prostate, CS cervix, colon, bladder, retroperitoneal fibrosis, can also lead to chronic obstruction, chronic interstitial nephritis, chronic use of drugs like analgesic, lithium, and cyclosporine, vesico-ureteric reflux in children and adolescents, chronic autoimmune diseases like SLE and Sjogren's, cystic diseases like ADPKD, heavy metal poisoning like lead, cadmium, mercury, and bismuth. These all are occupational neoplasm like myeloma, leukemia, and amyloidosis, and metabolic like hypercalcemia, hypokalemia, hyperoxaluria can also lead to chronic interstitial nephritis. Are varied causes of chronic interstitial nephritis. The clinical feature, you may find a history of analgesic abuse or obstructive uropathy or occupational history. Examinations usually feature chronic kidney disease, polyuria is common because it's a tubular damage, not the glomerular damage. Hyperkalemia because of kidney failure, raised urea creatinine, the same reason, reduced GFR, progressive disease because of the kidney failure, metabolic acidosis because of most of the signs are of chronic kidney disease. Urine measure, hematuria, pyuria, proteinuria, broadcast is a feature of chronic kidney disease and may present with WBC cast, but no RBC cast. Ultrasound usually shows small scarred, bilaterally small shrunken kidney or unilateral shrunken kidney because of obstructive uropathy. Treatment is treat the cause, example, surgical correction of obstructive uropathy, drug withdrawal, treat hypertension, fluid electrolyte balance, treat anemia, nutritional support, delay the progression. These all are the treatment of chronic kidney disease. And ultimately, if the patient lands up in end-stage kidney disease, renal replacement therapy may it be in the form of dialysis or transplantation, which we will be discussing in subsequent lectures. This was all about acute nephritic syndrome. We have discussed various causes of acute nephritic syndrome, its presentation and management, and we have also discussed the first form of tubular diseases like tubular interstitial nephritis. Tomorrow, in the next lecture, we will be discussing other tubular interstitial diseases like autosomal dominant polycystic kidney disease or cystic diseases of the kidney, renal tubular acidosis, and urinary tract infection. I thank you very much.